All right, well, thank you all for joining us today for our second webinar in our series, Urban to Rural Partners Working Together on Antimicrobial Stewardship. A couple little housekeeping items is that this webinar will be recorded and will be available for viewing at a later date on the CAP Center's website under the Resources tab, Continuing Education tab. Since we will be recording this session, we ask that all questions be placed in either the Q&A box or the chat, and we will answer them as time allows at the end of the presentation. There will be continuing education units available for pharmacists, and that CE code will be given at the end of the presentation. Nursing CE is also available, and a link to the evaluation form will be shared at the end, and a certificate of completion will be emailed to participants after the evaluation form is completed. I would like to thank North Dakota's Health and Human Services and NDSU's CAP Center for sponsoring the continuing education credits for the session. So without further ado, I'd like to introduce Dr. Tamara Ruggles. She is a board-certified geriatric pharmacist with over 10 years of experience as a consultant pharmacist in long-term care setting. She is the owner and operator of Specialty Pharmacy Consulting and the D-Prescribing Clinic. Other than antibiotic stewardship, she is passionate about pharmacogenetics, D-prescribing, and reducing anticholinergic burden. She and her husband live in Bismarck, North Dakota with their 7 children. So, Dr. Ruggles, thank you for presenting today.
Thanks for having me, Emily. Let's get started on UTIs and long-term care. I have no relevant financial relationships to disclose, and I will not be discussing any off-label use of medications today. There is our learning objectives. I'm not going to bore you and read them, but if you would like to read them, please feel free. So before we get started on asymptomatic bacteria versus urinary tract infections, I just want to first say that, oftentimes we think it's just a problem in our facility or in our state and in our nation, but this is a worldwide issue. The World Health Organization is constantly putting out publications on priority pathogens and issues we're having worldwide. And in one of the recent publications I read, they were calling, of course, for judicious use of antimicrobials, but one example they gave is more widespread fluoroquinolone resistance, especially when it comes to E. coli urinary tract infections. They stated in the publication that many countries have resistance rates as much as 50% to fluoroquinolones to treat those E. coli UTIs. And one of the priority pathogens is also Klebsiella, those resistant Klebsiella pneumonia pathogens, which I have seen in our state a little bit as well. So it's very important worldwide, for judicious use of antimicrobials so that our children and grandchildren will not have resistance issues. And so the World Health Organization also went on to say one of the main drivers of antimicrobial resistance, of course, is the misuse and overuse of antimicrobials. So we're going to address that a little bit today. What is the misuse? Well, it could be an inappropriate duration to treat a urinary tract infection. It could be an inappropriate antimicrobial choice, or it could be the overuse of antimicrobials. And that's why we're going to discuss the treatment of asymptomatic bacteria versus those urinary tract infections. And of course, it's also an issue in the United States and North Dakota level. We have those CMS regulations we need to follow, which talk about infections in many areas, including the infection preventionist, the antimicrobial stewardship program, enhanced barrier precautions, and all those fun regulations we get to look through all the time, but also the CDC and their core elements for antimicrobial stewardship programs. We've got our North Dakota state surveyors and UTIs on those CASPR reports. So that's kind of a more national and state level. And then in our facilities, of course, and with all of these regulations, we don't want to lose sight of the main purpose for being in healthcare, which is our patients. And so I'm in facilities all the time, and I see the wonderful care you all take of our nursing home patients. And so, of course, we want to continue to take good care, and we don't want to do any harm. And so we want to avoid doing harm by using antibiotics when it is appropriate, when there is a urinary tract infection, and by not treating patients that don't have a urinary tract infection. So I'm first going to start with just the difference between asymptomatic bacteria and urinary tract infections so we can see the difference there. So asymptomatic bacteria, what is it? Well, it's the presence of one or more species of bacteria growing in the urine at a specified quantitative count of greater than or equal to 10 to the 5 colony forming units per mil, and that's irrespective of pyuria or white blood cells or pus in the urine, and in the absence of signs or symptoms attributable to urinary tract infections. So how is it diagnosed? Asymptomatic bacteria is diagnosed in women as 2 consecutive specimens that are obtained to confirm the presence of the bacteria. In men, a single specimen is enough to meet the criteria for asymptomatic bacteria. And in our catheterized patients or patients who had a urinary catheter in the preceding 48 hours, 10 to the 3 colony forming units per mil of greater than or equal to 1 bacterial species is enough for a diagnosis. And if the organism is present in a low quantity than those specified, it likely represents contamination. So you'd want to draw a new urinalysis. So that's asymptomatic bacteria. You know, in a summary, you could say it's just 1 or more species of bacteria in the urine with no symptoms. So you got bacteria, but you do not have any symptoms that show you have a urinary tract infection. So what is a urinary tract infection? There's 3 different components. There's the clinical symptoms. So we want those symptoms to be there to have that diagnosis of a urinary tract infection. And those are localized to the urinary tract, or they could be some of those non-specific symptoms of infection, such as a fever, in the absence of symptoms suggesting an infection elsewhere. So you might have a fever, you don't see any cellulitis or any other type of infection, or you have those clinical symptoms, you know, like the burning urine or the pain with urination or something like that. And then, of course, laboratory evidence that suggests pyuria and bacteria, and then the absence of another infection or non-infection process to which the patient's symptoms can be readily attributable. So populations with a high prevalence of asymptomatic bacteria include patients with chronic indwelling catheters. If you have a catheter and it's in long enough, you're going to have asymptomatic bacteria. Older institutionalized populations, which is what we're talking about today, those long-term care patients, patients with spinal cord injuries, some patients with diabetes. As you know, sugar is conducive to bacterial growth. They have diabetes and they have sugar in their urine, it's going to be more prevalent to growing bacteria. And then for patients that can't get sterile urine despite intense antimicrobial use, we keep throwing antibiotics at them, but they just cannot have sterile urine. They just keep growing bacteria. Those are asymptomatic bacteria patients who are at high risk. So the guidelines recommend against screening for or treating asymptomatic bacteria in older adults residing in long-term care facilities. The guidelines go on to give some examples. So they say, well, what if there's an older patient with functional or cognitive impairment that has bacteria and delirium, but no local genital urinary symptoms or other systemic signs of infection? So we have an older patient, they might have functional and or cognitive impairment, and they have bacteria in the urine and delirium. Do we treat them? Well, the guidelines are going to suggest assessment for other causes and careful observation. So they don't suggest screening for asymptomatic bacteria in these patients that have delirium. They go on also to say, well, what if they experience a fall? If they experience a fall, should we, screen for asymptomatic bacteria? Again, the guidelines are going to say, assess for other causes and use careful observation over antimicrobial treatment. Now, guidelines also recommend against screening for asymptomatic bacteria in patients with short-term, which is defined as less than 30 days of an indwelling urethral catheter, and in long-term indwelling catheters. We're probably not going to screen because they're probably going to be growing some bacteria. There's no recommendation for or against screening for and treating asymptomatic bacteria at the time of catheter removal for patients for indwelling catheters. And this whole thing with patients developing bacteria after having a urinary catheter is because there's a universal formation of a biofilm along the indwelling catheter, which means all patients will ultimately develop that bacteria if the catheter remains intact long enough. So the acquisition of bacteria is about 3 to 5% per catheter day. And when you use antimicrobials in patients with catheters, it may delay the onset of bacteria, but it will not prevent it. They're eventually all going to have bacteria. So cliff notes on guidelines for screening for asymptomatic bacteria are, it's mostly appropriate for patients with urologic procedures and pregnancy and not really recommended in the rest of the population. I love these 2 points that the guidelines make because I think they're both great points to make for our antimicrobial stewardship programs. The first one the guidelines say is the non-treatment of asymptomatic bacteria is an important opportunity for decreasing inappropriate antimicrobial use, which I completely agree. We don't want to treat those asymptomatic bacteria patients because we want to avoid things such as C. diff infections, increased resistance, and other adverse drug effects. The other point that I really like is that they state obtaining urine cultures when not clinically indicated promotes inappropriate antimicrobial use. And I'll give an example. One day when I was working, there was a urine culture, and I can't remember exactly what it grew, but it was resistant to quite a few things. The primary provider had ordered a cephalexin, but it was resistant. And also the culture only grew 25,000 CFUs per mil. So I faxed the primary doctor back, let him know, hey, this culture is resistant to the cephalexin, and also it only grew 25,000 units CFUs per mil. Like, consider asymptomatic bacteria, or not treating in careful observation. But the primary then faxed it to the patient's urologist. The urologist then ordered nitrofurantoin, which the culture was also resistant to. So then I had to make a call to the urology office, and they ended up switching it to Cipro. But when I called the nursing home, the station, to let them know like what was going on and that I wasn't going to be filling the very first antibiotic ordered, I said, well, what's going on with the patient? What kind of symptoms do they have? And they said, well, their urine just smelled funny. So all that work for smelly urine when it was probably just asymptomatic bacteria. And in fact, didn't even grow to a quantity sufficient for a diagnosis of asymptomatic bacteria. So I think it's tough because it's so easy to see a patient and, they have funny smelling urine, or they have urine that looks funny. And all you have to do is fax the provider and get a urinalysis. And that patient is likely going to grow some kind of bacteria. And then the provider is likely to order an antibiotic to treat that bacteria. So I really like both of these points, that not treating asymptomatic bacteria is important for antimicrobial stewardship programs. And also that we need to be pretty judicious about who we order urine cultures for, and we can follow the Loeb's criteria, or whatever our policy states as far as when to get a UAUC. So that brings us back to criteria, and I like using both of these criterias. Both of them are used pretty widely, the Loeb and McGeer. I'm sure you're familiar with both of them. They have different purposes. So the Loeb criteria is great for that clinical use. So we're going to use it at the time where we suspect an infection to see if antimicrobial treatment is prudent at that time. So there's sort of a minimum set of signs and symptoms which will signal that the resident likely has an infection and that antibiotic initiation could be indicated, even if the diagnostic test results are not yet available. So you can use this Loeb criteria before you even get the urinalysis or urine culture back. Then we have the McGeer criteria, which is another nice criteria, but it's not great at the time of diagnosis because it requires some information that you may not have. And so we use this as a surveillance criteria. So when you have your antimicrobial stewardship meetings, you might say, we had 10 UTIs the past quarter, 7 of them met criteria and 3 didn't. And so when we say, the 7 met criteria, we're typically referring to the McGeer criteria for surveillance. And so this can be used retrospectively to count which ones were true infections. And then, of course, it depends on information that might be unavailable when clinical decisions are made, such as that urinalysis or urine culture. So 2 great criteria, just different uses for each. And so the Loeb criteria. The Loeb criteria is nice to try to decide at the time of assessment if the patient, if we do suspect they have a UTI and if we should consider treatment. So it has 2 different criteria, one for patients with a catheter and one is for without. So this first one is for patients with no indwelling catheters. So we can suspect a UTI if they have acute dysuria, which is painful or burning urination, or if they have a fever and one of the new or worsening of the symptoms. Now we have to remember, as we get older, we get colder, right? So our febrile response is blunted. So a fever is defined as 100 degrees Fahrenheit, which is a little less than we typically think of, or a 2.4 degree increase above baseline. So if we have a patient and their baseline temperature is 97.3, If they get to that 99.7, then we would consider that a fever. So 2.4 degrees Fahrenheit above baseline. And that's important to educate your nursing staff, because how many times do we take someone's temperature and say, oh, you're 99.7, you know, you don't have a fever. But for some patients, that would be considered a fever. So again, it's acute dysuria or a fever, and at least one of the following. Now, new or worsening is an important point to make there with the low criteria, because maybe the patient had urinary frequency before. So is it new or worsening? It's important to remember that when we're charting and looking at if we suspect a patient has a UTI. Is it more frequent than it has been, or is it the same? So the urgency, frequency, suprapubic pain, gross hematuria, costovertebral or CVA angle tenderness, and then urinary incontinence. So those are the criteria for suspecting a UTI, getting that urinalysis, and then treating the patient. And then patients with an indwelling catheter, if they have at least one of the following, you could suspect a UTI, which would be a fever, new CVA tenderness, rigors, or new onset delirium. Now, I want to point out that in the guidelines on the asymptomatic bacteria, they recommend not screening for delirium. However, in a patient with an indwelling catheter, it may be appropriate to screen for bacteria with new onset delirium. So it was kind of, in healthcare, there's always an exception to every rule, right? So with delirium and a catheter, you may want to suspect a UTI. I like the note that they put at the bottom of the low criteria in the Minnesota Department of Health, that foul smelling or cloudy urine is not a valid indication for initiating antibiotics. We could always do a better job with hydration in our skilled nursing facility and long-term care patients. And so that could be why their urine looks funny or smells funny. Maybe they're dehydrated. And then asymptomatic bacteria should not be treated with antibiotics. So that's the low criteria for when deciding if a UTI, is suspected and if treatment should be followed. Now, we also have the McGeer criteria. And so the McGeer criteria is a little bit more cumbersome. And so a UTI without an indwelling catheter, you have to fulfill at least something on point number 1 and point number 2. And then it gives you a few different comments. I'm not going to read through the whole thing because I think that's going to be boring for you, but just know that it's good to use for that surveillance. And so when you're surveying to see if you met criteria in your antimicrobial stewardship committees, you can use this criteria. And then that's with an indwelling catheter. So that is the McGeer's criteria. So let's go over a case. So case 1 is Dorothy, and she's a 78-year-old female in a skilled nursing facility. She fell trying to self-transfer and hit her head. She was sent to the emergency department for evaluation, and while she was there, a urinalysis was ordered. Her laceration was stitched, and she was sent back to the facility with an order for Cipro 500 BID for 7 days. She has no urinary symptoms the day of the fall and still has no complaints, no reported dysuria, fever, chills, or urinary frequency, no catheter. So what would you do for Dorothy that went to the hospital and came back with some Cipro ordered? Well, the appropriate thing to do in this case would be to get the antibiotics stopped. D, clearly she has asymptomatic bacteria and treatment would not be indicated for this patient. So I like the person's thinking for A and C, because if she truly did have a UTI, it would be good to check the duration to see if it follows the Infectious Disease Society of America guidelines. And it would also be good to have that antibiotic renally dosed if it wasn't true UTI. So it's good thinking. But in this case, it's simply asymptomatic bacteria. The patient has no symptoms. And so we would want to call the provider and get that antibiotic stopped. There is no need to treat Dorothy for 7 days without a true urinary tract infection. But unfortunately, we see this all the time in long-term care, don't we? So next is just a tool to use. So I wanted this to be very practical as far as tools to use in your long-term care facilities to help decrease UTIs. And an antibiogram will certainly help with that. It's a great tool to use to report and track susceptibility data. It's a great guide if you need for empiric antimicrobial therapy. If you have a high resistance pattern to one antibiotic, you wouldn't want to use that for empiric treatment. And so, of course, it also supports compliance with antimicrobial stewardship requirements from both the Centers for Medicare and Medicaid and in line with the CDC's core elements. So before I talk about strategies, I just want to say that an antibiogram is actually pretty simple to make if you don't have one for your facility. There are programs out there if you want to download them, but if you want one for your facility, you can use a simple Excel spreadsheet is what I use for my facilities. And all you have to do is kind of put the bugs on the left column and the different antibiotics on the top, and you just go through each of those urine cultures and you write, which one was susceptible or resistant. And then at the end, you go through, and if you had, let's say, 35 cultures for E. coli and 7 of them were resistant to Cipro, then you would just calculate your susceptibility and resistance rate. So then you'd have 80% susceptible and 20% resistant to E. coli for Cipro. So it's easy to use that Excel sheet. And if you have questions on how to do that, you could certainly reach out to me. Another great way to get an antibiogram is if you just use one lab for your whole facility. That lab would probably be able to make an antibiogram for you. I can run into problems when I have facilities that use 2 different labs. And so it's kind of hard to, get both antibiograms from each lab and kind of combine them. But if you just use one lab predominantly, that might be an easy way to get your hands on an antibiogram is to call your lab. And as I'm talking about that, calling the lab, those people know so much. So if you ever have questions on resistant organisms, they are very helpful. Another way to get an antibiogram without having to make one yourself is the North Dakota Department of Health and Human Services on their website have several antibiograms. I will show you some in just a minute, but if you don't have one for your facility and there's one on the website from a neighboring community, you might be able to use that one. And so when you, if you decide to make an antibiogram for your long-term care facility, sometimes places have a low number of cultures. So antibiograms, it's nice to have at least 30 cultures for each bacteria in order for it to be accurate. And so if you don't have 30 cultures for each bug because you have a smaller facility or not a lot of UTIs, I listed some strategies if you have those low number of isolates in order to make your antibiogram a little bit more accurate. One strategy is you could extend the isolates data beyond 1 year. So instead of using 1 year of cultures on your antibiogram, you could include 2 years of cultures. Or you could combine isolate data from the same region. So let's say, you live or your facility is by 3 other facilities. So maybe you guys could combine your data and to make it a little more accurate by your region. You could also use a nearby acute care facility's antibiogram as a proxy, which check the website for the North Dakota Health and Human Services and see if they have one on there that you could use. Or you could collapse isolate data, which I tend to do for my facilities. And instead of saying, we have a 8% resistance rate for E. coli to Cipro, I just say as a facility, our resistance rate to E. coli is this. So I collapse the isolate data to make ours a little more accurate. But an antibiogram is a very nice thing to use. It's a nice thing to have on hand for providers if you suspect an infection. And that way you can kind of show them what the best empiric treatment option might be. And so here's an example. This is an antibiogram from the North Dakota Health and Human Services website, which the link is down on the bottom of this slide if you want to go check it out. So this is Sanford Fargo's outpatient urine antibiogram for gram-positive bugs. And so you can see how to use this. You'll notice the ones with less than 30 isolates are flagged due to low accuracy. But if you look at the Enterococcus faecalis, the first one, there was 324 isolates. And so if you suspect a patient had one of those, you can look and say, oh, we don't want to use tetracycline because it's only a 33% susceptible rate, which it would be better to use one of the others with a higher susceptibility rate. And so that's kind of how you use it. You find the bug and you kind of look down at the susceptibility rates and you want to pick one for empiric treatment that has a high susceptibility rate so that there's a high rate of cure for your patients. Here is an antibiogram from, again, Sanford Fargo Outpatient Clinic, but this one is for those gram-negative bacteria. As you can see, the #1 bug cultured in UTIs is E. coli, which is very obvious here too, with 4,406 cultures. So that's quite a number. That's a very accurate antibiogram for the E. coli then. And so you can look and see, oh, if you don't want to use probably ampicillin to treat that UTI, you'd want to use something more like nitrofurantoin, 98% susceptibility, and it's a well-tolerated antibiotic. So that's kind of how you use it. So based on the Sanford Fargo Outpatient 2024 urine antibiogram, which would be the most appropriate treatment choice for empiric treatment for a patient with a history of ESBL producing E. coli? Would it be sulfamethoxazole trimethoprim, Cipro, levofloxacin, or nitrofurantoin? And so if we look at ESBL E. coli, which one would we want to use? Well, Cipro only has a 32% susceptibility rate. Levaquin has a 25% susceptibility rate. Sulfamethoxazole trimethoprim has a 41% susceptibility rate, and nitrofurantoin has a 93% susceptibility rate. So as long as the patient had good kidney function, we would definitely want to use nitrofurantoin based on the 130 isolates that were tested in this antibiogram. So next, we want to talk about appropriate antimicrobial use and identify some side effects of UTI treatment. So nitrofurantoin is so widely used. I will say before I talk about each of these antimicrobials that I want to highlight duration of use, because I think that's an important way that we can improve with UTI treatment is looking at those durations. So the IDSA guidelines for the treatment of uncomplicated UTIs has been archived, and it is set to be published this quarter, the updated guidelines. And I was so hoping they would be published before this talk so I could go over the new durations. But unfortunately, although I've been checking every day, they are still not out because I checked this morning. But when those come out, so it's just on the Infectious Disease Society of America website, you can go and they'll have an alphabetical listing of guidelines, and you can scroll down to UTI. And when they're published, I think a great project that can be used in the antimicrobial stewardship program is to look at those recommended durations for the treatment of uncomplicated UTI and implement some of that data in your facilities, because we treat UTIs for way too long when it's not necessary to do so. And studies show that you're not going to get more of a cure or a better cure, but you are going to have increased side effects when you treat for a longer duration than necessary. And so in one of my facilities in 2019, we decided to implement a duration cap policy for the treatment of uncomplicated UTIs based on the IDSA guidelines. And so when we did that, our average duration of antimicrobial use went from 7.25 days to 5.86 days for the treatment of uncomplicated UTIs. And so it went down by nearly 2 days per patient, which is very significant. We're not aware of any adverse effects that happen because of that policy. And our Cipro resistance rate in that year went from 20.6 to 17.2%. And our sulfamethoxazole trimethoprim resistance rate went from 26.7% to 13.5%. So it was effective. We still do it to this day. I will say I had to write the policy, but other than that, I haven't done a ton with it because the provider pharmacy that gets the orders has been amazing at implementing that policy. And so there's a duration cap limit if it's an uncomplicated UTI. If the provider still wants to write for longer than recommended, they can. They just fill out a short exemption form. And that's happened maybe 2 or 3 times since 2019. Other than that, providers almost always decrease the duration to what we have specified in our policy. So that's something that you could think about for your facility if you think that providers are writing for too long of a duration for those uncomplicated UTIs. So back to the nitrofurantoin. The recommended duration for acute uncomplicated cystitis in females is 5 days and in males 7 days. And for UTI prophylaxis, the dose is 50 to 100 milligrams QHS. And I just want to point out that for both postcoital prophylaxis and continuous prophylaxis, only the macro crystals, which is brand name macrodantin, is FDA approved for prophylaxis. The nitrofurantoin monohydrate macrocrystals, brand name Macrobid, is not FDA approved for prophylaxis. So that is something to be watchful for when providers write for nitrofurantoin for prophylaxis. It should only be the macrocrystals, brand name Macrodantin, not the Macrobid that's used for prophylaxis. And then for UTI prophylaxis, the recommended duration is 3 to 12 months with periodic reassessment. It's important to note that prolonged use, which is defined as greater than 6 months, has been associated with diffuse interstitial pneumonitis and or pulmonary fibrosis, chronic hepatitis, and the development of neuropathy. So we really want to be careful when we're using it long-term. Always avoid in patients with a creatinine clearance less than 30 because it will not reach a sufficient quantity to treat the UTI. It will be ineffective. And notice it has creatinine clearance and not estimated GFR, which is always on the chem panel. And so you may have to calculate that creatinine clearance, which if you just go to Google, they have creatinine clearance calculators and you can plug in all the numbers and it'll tell you the patient's creatinine clearance. If there's a creatinine clearance of 30 to 60, it's contraindicated in the manufacturer's labeling, but there is data to show it's safe and effective for short-term use. So when we're using it for long-term prophylaxis, we want their creatinine clearance to be above 60. When we're using it for short-term use, 30 to 60 looks like it's safe and effective according to data, and then never use it with creatinine clearance less than 30. And then we never want to use it for those upper urinary tract infections such as pyelonephritis because it will not be effective. One thing to keep in mind is that although a patient may start nitrofurantoin prophylaxis when they have good kidney function, it's important to recheck chem panels periodically to make sure their kidney function is still sufficient to use nitrofurantoin. So I always suggest checking a chem panel at least every 6 months to ensure that their kidney function is good enough to support the use of prophylactic nitrofurantoin. Adverse reactions that are common with nitrofurantoin are headache and nausea, and then we have those more significant adverse effects, which include a C. diff infection, drug-induced liver injury, peripheral neuropathy, and the pulmonary toxicity. Those bottom three seem to be quite a bit higher in patients who are on nitrofurantoin long-term. So when I looked at studies to see, well, how common are those serious side effects with patients prescribed nitrofurantoin? They did a study in 3,400 patients that were at least 65 years old. Of those, 89% had no adverse reactions, 7% had minor side effects or allergies, and 3.9% of those patients met criteria for a suspicion of nitrofurantoin-induced adverse event. Of those 3.9%, 5 were rated as highly suspicious for nitrofurantoin toxicity, so 5 of the 3,400 patients. 4 of those patients had pulmonary toxicity, and 1 of those patients had hepatotoxicity. And so the study noted that chronic use posed the greatest risk for serious side effects. There was limitations to this study. They excluded all patients with an estimated GFR less than 60. And so we know that declining kidney function puts patients at a higher risk for these serious adverse events. So that could be why the numbers were so low. And they also did not look at peripheral neuropathy. So although these serious side effects seem to be rare, about 0.15% in this population, it's important that we watch out for them. And it's also very important to watch that kidney function so that we can discontinue nitrofurantoin in patients who have creatinine clearance less than 60 when used for prophylaxis. We need to get that discontinued so we don't put them at higher risk for these serious side effects. Then we'll move on to trimethoprim sulfamethoxazole. The recommended duration for females is 3 days, males is 7 days. And for UTI prophylaxis, I often see this dose a little bit higher than recommended. So the recommended dose is 1/2 of a single strength tablet once daily or 3 times weekly. And I often see a double strength tablet ordered daily for UTI prophylaxis. So if we get that order, we need to clarify and remind providers of the recommended dose. The duration for prophylaxis is 3 to 12 months with periodic reassessment. Again, optimal duration is not established. I know in my facilities, I will leave a note every 6 months with patients with UTI prophylaxis to have it reevaluated to see if there's a need for it to continue. And it's important to look at how many UTIs they've had in the previous 6 months if prophylaxis is still something that the patient needs. So significant adverse reactions with brand name Bacterium or trimethoprim sulfamethoxazole. A C. diff infection with all these antibiotics we're going to talk about today. Drug-induced liver injury, that's why it's important to get those Chem 14 panels so we can check their liver function periodically. Hematological effects, that includes some blood dyscrasias such as agranulocytosis, hemolytic anemia, leukopenia, and thrombocytopenia. Now, the risk of hemolytic anemia is increased in patients with G6PD deficiency. So another reason to get them pharmacogenomic tested to see if they have G6PD deficiency and are at higher risk for hemolytic anemia. The high potassium or hyperkalemia is common with Bactrim, hypoglycemia, hyponatremia. And then, of course, we have those hypersensitivity reactions that we know are somewhat common with Bactrim. The immediate hypersensitivity reactions include urticaria, angioedema, and anaphylaxis. Those are those IgE-mediated, not dose-related adverse reactions. And then the delayed hypersensitivity reactions, which could occur days to weeks after starting Bactrim, include a skin rash, fixed drug eruption, severe cutaneous adverse reactions such as Stevens-Johnson's or toxic epidermal necrosis. Those are those T-cell mediated adverse events, and they're not dose dependent. They're immune mediated. So we always have to watch out for rashes with sulfamethoxazole trimethoprim, and then monitoring those chem panels for the potassium and the liver injury, and then a CBC for those hematologic effects. So it's very prudent if a patient is on trimethoprim sulfamethoxazole long-term for prophylaxis that we are doing routine monitoring of CBC and Chem 14. Then we have those beta-lactam antimicrobials such as amoxicillin clavulinate, the cefpodoxime, cefdinir, cefadroxil, and cephalexin. I will most often see cephalexin or amoxicillin clavulinate for the treatment of urinary tract infections in my facilities. The recommended duration for the acute uncomplicated cystitis with these agents is 5 to 7 days. And with the beta-lactam antimicrobials, the most common adverse effects are diarrhea, nausea, vomiting. I always think of diarrhea with the beta-lactams. And so it's okay if it's mild, but if it gets to be severe or persistent, we certainly want to contact the doctor and think about switching to something else because we don't want it to lead into a C. diff infection. So significant adverse reactions include an antibiotic-associated diarrhea, Clostridium difficile infection, drug-induced liver injury. That one is with Augmentin, my apologies. It's not amoxicillin, it's Augmentin that can have the drug-induced liver injury. It appears to be immune-mediated. Not sure if it's due to the amoxicillin or the clavulanic acid or the combination of both, but it can happen with that medication. And then hemolytic anemia with the cephalexin, so especially if they have the G6PD deficiency, and those hypersensitivity reactions, just like the ones we talked about for the Bactrim, those immediate and delayed reactions. Then we have fosfomycin. I don't know about in your facilities, but I've seen less use lately with fosfomycin in mine. The recommended duration for acute uncomplicated UTIs is 3 grams as a single dose. And then for continuous prophylaxis, the dose is 3 grams every 7 to 10 days. I've actually never seen any of my patients on fosfomycin for continuous prophylaxis, but it does have that FDA indication. The duration is 3 to 12 months with periodic assessment. And then those adverse reactions with the fosfomycin that are common are diarrhea, nausea, vaginitis, headache, and rhinitis. So more significant adverse effects are a C. diff infection, electrolyte disturbance. When I look more into the electrolyte disturbances, that appears to be an IV formulation used in Canada. It doesn't really appear to be used with the oral formulation. So I think you can kind of cross that one off your slide. You get those GI disturbances such as dyspepsia, nausea, and then those hypersensitivity reactions, both immediate and delayed. So ciprofloxacin is one that's used somewhat often. I think since there's been a bigger push to use agents that have less harm, that it's been better. The recommended duration for acute uncomplicated cystitis is 3 days. In males, it's 5 days. Common reactions are diarrhea, dyspepsia, nausea, and vomiting. But you can see when it comes to significant adverse reactions, there's quite a bit more with ciprofloxacin than the other agents. And in fact, the US has a boxed warning that says fluoroquinolones has been associated with disabling and potentially irreversible serious adverse reactions. The boxed warning goes on to say that to reserve ciprofloxacin for use in patients who have no alternative treatment option for the following indications. And one of those indications is acute uncomplicated UTIs. So the US box warning makes it very clear that there is disabling, potentially irreversible side effects, and if possible, to use a safer alternative for patients with acute uncomplicated UTIs. And luckily, I do think the use of ciprofloxacin has gone down since more awareness has been made of the potential harms. And so those significant adverse reactions, the aortic aneurysm and aortic dissension, those joint disease and joint pain issues with arthralgia and arthropathy. CNS effects or neuroexcitation. The CNS effects can range from confusion to hallucinations to psychosis. I remember every time my grandpa was on ciprofloxacin, he would hallucinate. And so it seemed like if I ever called the doctor and got the dose cut in half, that his hallucinations would go away. He didn't have renal impairment. I don't know why a higher dose seemed to affect him as much, but I remember walking in his house and he thought he was eating an ice cream cone, but he was completely hallucinating. There was no ice cream there. And so that really used to affect him. So that's an example of one of those CNS effects of ciprofloxacin. Clostridium difficile infections, the glucose regulation, that can be either hyperglycemia or hypoglycemia. Definitely need to monitor our patients for both of those. Hepatotoxicity, again, we want to check those chem panels to make sure that there's no liver injury. Hypersensitivity reactions, both immediate and delayed, like our other antimicrobials. It can aggravate myasthenia gravis, ciprofloxacin can cause peripheral neuropathy, phototoxicity and photoallergy or sensitivity to light. QT prolongation is a big one, so we really want to watch out for the QT prolongation. It seemed to be a higher risk for females and those above 65 years of age and underlying disease. Also with that QT prolongation is other medications that could also prolong the QT interval. So your pharmacy definitely want them to do their due diligence in checking for drug-drug interactions. And then last, that tendinopathy or tendon rupture. That seems to be most common in the Achilles tendon, but it can occur in the hand, in the thumb, in the bicep, and the rotator cuff. And so if you have a patient on ciprofloxacin complaining, especially if it looks swollen or they're complaining of pain in any of those areas that have those tendons, I would stop the antibiotic and call their provider for instruction. It is that patients are at higher risk for a tendon rupture and tendinopathy if they're above 60 years of age and using concomitant corticosteroids. So I always think of those patients who have pneumonia and they're put on prednisone and levofloxacin and they're older adults. So they would be at the highest risk for having a tendinopathy or a tendon rupture. So something to watch out for. And if they complain of pain, certainly take it serious and assess them for a tendinopathy before. If you don't catch it right away and it worsens, it can rupture. So if they complain of pain, be sure to check and assess right away. And so our next question is, a patient is on continuous antimicrobial treatment for recurrent UTIs. Her most recent chem panel showed a potassium level of 5.3 milliequivalents per liter. Hyperkalemia is a side effect of which antimicrobial? What would you think it would be? Nitrofurantoin, sulfamethoxazole trimethoprim, fosfomycin, or ciprofloxacin? And the answer is B. Sulfamethoxazole trimethoprim can cause high potassium levels. And we will talk about that more in just a minute, as far as what also might increase your risk of having high potassium with Bactrim or sulfamethoxazole trimethoprim. I know I'm not supposed to use brand names, but man, it's kind of a bugger to pronounce the sulfamethoxazole trimethoprim every time we talk about it. So I've given you a few different tools as far as antibiogram, some criteria, when it's asymptomatic bacteria and when it's a UTI. But another great tool we have in long-term care is the Beers criteria. And I don't know if you've heard of the Beers criteria, you probably all have, but it's a really great tool for anyone in long-term care to use. There was a geriatrician named Mark Beers who started this criteria in 1991 and just started it as a list of potentially inappropriate medications in older adults and then gave some reasoning and research. And in 2011, the American Geriatric Society took over the Beers criteria, and they have done a great job about updating it as evidence comes out and putting it into different tables, with a lot of user-friendly tools. And so it is free to download the PDF. It's a 30-page file, but it's nice to download on your computer. And then if you're wondering about anything, use that Control F or that find function to look for different medications on the Beers criteria. It's something I use almost every day. And so again, it's a free tool to use if you want to download it. But Table 2 of the AGS 2023 Beers criteria lists potentially inappropriate medications in older adults. And in that table, one of the medications listed is nitrofurantoin. And you'll see that the rationale for nitrofurantoin being potentially inappropriate is that potential for pulmonary toxicity, hepatotoxicity, and peripheral neuropathy, especially with long-term use. And so they suggest that safer alternatives are available. And so the recommendation is to avoid in patients with a creatinine clearance less than 30 or avoid for long-term suppression. So if a patient has a creatinine clearance less than 30, we want to avoid the medication altogether. And remember, if their creatinine clearance is less than 60, we do not want to use for long-term suppression. But the Beers criteria takes it a little bit of a step further and just does not recommend it at all for patients for long-term suppression due to the risk of those side effects. So Table 4 of the AGS Beers criteria lists those potentially inappropriate medications that should be used with caution. And so the ones that should be used with caution include trimethoprim sulfamethoxazole, and the rationale is an increased risk of hyperkalemia or hypotassium when used concurrently with those ACE inhibitors, ARBs, or ARNIs. ARNI is like Entresto, sacubitril, valsartan, so it includes an ARB in it, and that's why that's included, in the presence of a decreased creatinine clearance. So they want us to use caution when using trimethoprim sulfamethoxazole with an ACE inhibitor or an ARB. Why? Because the combination of the two can increase their potassium, especially with a decreased creatinine clearance. So when you think of those ACE inhibitors, they end in pril, like lisinopril. And when you think of those ARBs, they end in sartan, like losartan, olmesartan. So those are the meds we might want to avoid with trimethoprim sulfamethoxazole to avoid that increased in potassium, because each of those medication classes alone can increase potassium. And then when you combine the two, you have a further increased risk. Table 5 of the AGS Beers criteria lists important drug-drug interactions that should be avoided in older adults. And you'll see warfarin with trimethoprim sulfamethoxazole and warfarin with Cipro have an increased risk for bleeding. And so the criteria recommends avoiding those combinations if possible. If used together, we need to monitor those INRs closely. Adding Cipro or trimethoprim sulfamethoxazole with warfarin will increase the risk of bleeding. And so we want to be really prudent. You can ask your doctor, do they want to preemptively decrease the dose by 10 to 20%? Or are you going to monitor an INR in a day or two after starting one of those antibiotics? Because we don't want our patients to end up in the hospital with a bleed because they started one of these antibiotics. And then Table 6 of the AGS Beers criteria talks about medications that should be avoided or have their dose reduced with varying levels of kidney function. And so you'll see on this table that Cipro, fluoxetine, nitrofurantoin, and trimethoprim sulfamethoxazole are all included. They all use creatinine clearance instead of that estimated GFR. So we need to calculate that with our chem panel to see what their creatinine clearance is. Many times an estimated GFR will be higher than a calculated creatinine clearance because we might only have a serum creatinine of 1.2, but our 90-year-old lady weighs 80 pounds. And so our creatinine clearance is going to be pretty low. So those are the drugs that require action with a creatinine clearance less than 30. And you'll see nitrofurantoin should be avoided with less than 30. And then with ciprofloxacin and trimethoprim sulfamethoxazole, there are dose adjustments that are recommended. And your consultant pharmacist or your provider pharmacy could certainly do those renal dosing for you. I recommend that every antibiotic is renal dose for every patient every time, and that could be done by your pharmacy, by your consultant pharmacist, by somebody. It's very important to do that for the safety of our patients. So UTI prophylaxis, recurrent UTIs are defined as greater than equal to 2 in 6 months or 3 in a year. One important thing is fluid intake. So a study of 140 randomized premenopausal women showed that increased fluid intake decreased the incidence of cystitis by about 50%. So it's very important that our patients are getting enough fluids, and you can be creative with root beer floats or popsicles or whatever you can do to get fluids in these patients. Hygiene and pericare is important. Since I am a pharmacist, I don't know a lot about that, but I know our nurses on this call certainly do. And then topical estrogen. Topical estrogen has kind of been the hype, I guess, as far as UTI prophylaxis goes, because it normalizes the vaginal flora, it decreases the risk of vaginal atrophy, and it also lowers the vaginal pH. And so it creates a more healthy environment for women and less incidence of UTIs. So I'm a fan of using Premarin for UTI prophylaxis if your provider agrees. Also, when you have vaginal atrophy, you can have the burning, the dryness, and more UTIs. So correcting that can help lower your incidence of UTIs. Other antibiotic sparing strategies are methenamine, cranberry, D-mannose, and probiotics. Not a lot of these have evidence to support their use. I think for cranberry, D-mannose, and probiotic, that there's not evidence to say it's really effective. The evidence is limited. I kind of think, if you're desperate, try it. There's not a lot of harm to using these. But if they're not effective, discontinue them, because we don't want to contribute to polypharmacy and unnecessary spending. I will talk about the methenamine in a minute. I actually do like that product as an antibiotic sparing strategy. And then for UTI prophylaxis, we have our antimicrobials. And the choice is going to depend on the patient's susceptibility patterns, allergies, and potential for drug interactions. Also, their kidney function. We can't forget their kidney function. So here's a study of methenamine, and it was a good study. I like it. There was 240 adult women in the study. 120 received methenamine. 120 used antibiotics. And it was a non-inferiority trial. So during the 12-month study, there was 0.89 UTIs per patient year in the antibiotic group and 1.38 UTIs in the methenamine group. So the absolute difference was 0.49. And so in order for there to be no difference between methenamine and UTIs, the number would be closer to 0. And in order for there to be, to show that methenamine was inferior, the number would be closer to 1. And so since that number was at 0.5, it showed that methenamine is non-inferior to antibiotics. And so it's a nice antibiotic sparing method to use for UTI prophylaxis. All it does is it's hydrolyzed to formaldehyde in the urine, which has a non-specific bactericidal action. And so I think it's a good option to use before you go to an antibiotic. Here's a study they did that showed that there are risks associated with urinary tract infection prophylaxis in older adults. And what they showed was patients who are on prophylaxis compared to patients who are just treated for a normal course for a UTI and then the antibiotic was stopped. The patients who received prophylaxis had a 1.3 times risk of hospital visits, 1.3 times risk of antimicrobial resistance, 1.6 times the risk of C. diff, and 1.6 times the risk of side effects. So there's certainly risks associated with prophylaxis. An antibiotic timeout is an awesome tool to use. I think we have to look and see, make it simple, because if we just give nurses another thing to do, they're just going to click through it and it's not going to be effective. And so what an antibiotic timeout does is it just reassesses the need for antimicrobial treatment 48 to 72 hours after the first dose. And so you could have them look at culture and sensitivity, response to therapy, the drug, the dose, the duration, or de-escalation. I think keep it simple. Like an appropriate antibiotic timeout might just say, is there a culture for the bacteria the antibiotic is treating? Yes or no? If no, that's the end of the antibiotic timeout. If yes, you can say, is the organism sensitive to the antibiotic ordered? Yes or no? So that antibiotic timeout could simply look at sensitivity. You could have another antibiotic timeout that just simply looks at duration. Is this antibiotic used to treat an uncomplicated UTI? Yes or no? If yes, these are the IDSA guidelines. Does the duration follow those guidelines? If no, then maybe notify your infection preventionist to get the duration shortened according to IDSA guidelines. But we don't want to give nurses just another thing to do. We want it to be effective. So I think keep it short and sweet and pick the one thing you really want those nurses to look at during that antibiotic timeout. So I do like it. I think it's effective, but let's keep it short and sweet so our nurses can focus on patient care. Here's a case, Isa. She's a 72-year-old female residing in our long-term care facility. A few days ago, she developed dysuria and had a temperature of 2.5 degrees above baseline. She met criteria for a UTI and was treated with sulfamethoxazole trimethoprim, double strength twice a day for 10 days for E. coli. It's been 48 hours since the antibiotic was started and the nurse is completing Isa's antibiotic timeout. Her symptoms have improved and she no longer has a fever. So here is her culture. What would be an appropriate intervention at this time? Should she be switched to nitrofurantoin? Should she ask the provider to reassess the duration based on current guidelines? Should she continue the antibiotic because Isa is doing well, or should she just check the boxes to get the antibiotic timeout over with? Well, I don't think you need to switch to nitrofurantoin because this culture is sensitive to the trimethoprim sulfamethoxazole. But I do think it would be appropriate to reassess the duration because it was written for 10 days. And she should really only need a 3 to 5 day course of antibiotics according to IDSA guidelines for an uncomplicated UTI. So I would recommend B, ask the provider to reassess the duration based on current guidelines. And I am not going to go over these core elements for antibiotic stewardship because I'm sure you have all seen them 100 times. The point I wanted to make with this is that sometimes when you feel stuck with your antimicrobial stewardship program or stuck with UTIs and you're not sure what to do next, it is nice that they have the CDC provided a checklist for you that follows these 7 pillars of antimicrobial stewardship. And so those are the 7 pillars. And for each of the 7 pillars, they have a checklist, which I think is really great. And I think you should review it yearly as either an infection preventionist or an antimicrobial stewardship committee. You can just go through and check off what you've done. And you don't have to check off every single one. Maybe make it a goal to check one more off the list each year. Or just go through it to give you an idea of what to do. As you'll notice under 5, an antibiogram is listed under 5. Also an antibiotic timeout is listed under number 5 under actions to improve. So we've talked about a few things you can do to implement a more appropriate antimicrobial prescribing habits in your facility, but this checklist is just another tool to use along with the antibiogram, the antibiotic timeout, and those other tools I've given you today. So you can read through those, and they're on the CDC website. So case 3 is Martin, and he's an 83-year-old male living in your skilled nursing facility. His family came to visit and said he is more confused than usual. They think he has a UTI. What do? You call the on-call doctor and get an order for urinalysis. Do you check Martin's urine color? Do you assess the patient for a fever or symptoms of a UTI, or do you ask the kitchen to send up some cranberry juice? Of course, the answer is C, assess the patient for a fever and or symptoms of a UTI. So we don't want to call the doctor and tell him that he's confused and ask for a urinalysis. First, let's do a proper assessment on the patient. Is he having dysuria? Does he have a fever? Does he have that CVA tenderness or any symptoms on that Lopes criteria? And while you're doing that, I know families can be scary. You can say, hey, yes, I'll come assess him for a UTI while I'm doing that. Would you be able to try to get him to drink 8 ounces of liquid or just try to push a little more fluids? And so you can get everyone to help you push fluids. You can get, you can get nursing, you can get activities, you can get therapy before they leave therapy. Can you drink some fluid? You worked really hard today to try to prevent some of those UTIs through hydration. And the last question is, which of the following are ways to improve your antimicrobial stewardship program? A, measure outcomes related to antibiotic use. B, have your consultant pharmacist review antibiotic courses for appropriateness. D, develop facility-specific treatment recommendations for infections. Or D, all of the above. And the answer is D, all of the above, because they were all on that checklist provided by the CDC. And so, again, thank you for taking such amazing care of our long-term care residents. And I think we can all take some ownership and appropriate use of antimicrobials. Pharmacists, nurses, providers, we can all do a better job, and we can never forget it's about the patients. And so that's why we're here. And please reach out if you have any questions.